Okay, welcome back to part 2 of renal disorders. So we left off talking about differences between cystitis and UTIs. So cystitis is referring to inflammation of the bladder, which we talked about can cause various issues, including infections, irritants, or underlying medical issues. And then UTI is just a broader term that refers to any type of infection of the urinary system, which is kind of just think of like the UTI being like the mothership of the urinary system within the bladder. So it can cause cystitis, urethritis, polynephritis, and prostatitis. So cystitis being inflammation of the bladder, urethritis is inflammation of the urethra. Polynephritis is infection of the kidneys, and then prostatitis is the infection of the prostate, of course, specifically in men. So acute polynephritis, which is diagnosed by clinical symptoms. It causes bacterial colonization, adherence and invasion, inflammation, and immune response. And it can cause renal injury and complications. So diagnosing acute polynephritis is can be difficult sometimes in clinical symptoms because it can be, and it can appear to be just regular cystitis, but typically it's due from untreated cystitis that's now traveled up in the upper portion of the tract, which is more considered an upper UTI, and cystitis involves the lower tract. The differentiating symptoms are, though, for polynephritis, it's just that flank pain, typically abdominal tenderness. Sometimes they can have the intercostal pain too that can kind of wrap around to their back, which is more kind of like that flank pain too. The presence of systemic signs such as a high fever, chills, they may present with tachycardia and suggest a severe infection. So diagnosing polynephritis would obviously be a urinalysis, and they are going to present with white blood cell casts that are indicating polynephritis, but the white blood cell casts might not always be present, but we can follow this up with confirmation to see if they have elevated white blood cell count. That would obviously be indicative of infection with a CBC. We can also do renal ultrasounds or like CT scans to kind of look at the structural abnormalities to see if they have any type of extrusion or abscesses. So how are we going to treat acute polynephritis? We're going to use antibiotics. So we need to also use supportive care, making sure they're getting adequate hydration, using some analgesics, maybe like some NSAIDs that can help manage their symptoms to promote recovery with pain management. Maybe in some severe cases, patients might need to be hospitalized. Maybe ones with have some underlying comorbidities, or maybe those that are intolerable for oral intake might need some IV fluids or IV antibiotics, and maybe some close monitoring. I think of those maybe with more of like your pregnant women or elderly that maybe need some extra monitoring just to make sure that they are safe, and maybe some children too, depending on what they might require. So the follow-up is very crucial to monitor their treatment response, and then making sure that we are adequately teaching them that it is very, very important that they complete their full course of antibiotics to ensure the full resolution of the infection is through, and that way they don't come back and end up getting a superbug and having to use some stronger antibiotics. A lot of times patients will stop taking their antibiotics because they feel better. It's very important for us to educate, follow through, and making sure that they finish all of their antibiotics. And then, of course, have follow-up visits, and we might need to repeat some blood cultures. So renal calculi is where it's a supersaturation where the urine becomes oversaturated with certain substances like calcium. So that's where the calculi is coming from. It's like calcium. It's crystals that act as nucleation sites where further crystal deposition can occur. Crystal retention can inadequately cause urine flow issues, which is allowing crystals to remain in the urinary tract. And that's where those can compile, and they can actually cause stone growth. And as the crystals accumulate and continue, they can coagulate together and grow stones. So that's where you're going to end up with renal calculi, which is stones. So physical exam, signs and symptoms that the patient's going to have some renal calculi would be flank or abdominal pain, intervertebral angle tenderness. So they might actually have this as well with the renal calculi. And then some hematuria. And study images are crucial for assessing the presence and the size and location of the stones. So we would need to know how big these stones are in order if these patients are going to be able to pass these stones or if they need to have them removed. So that's why we end up wanting to do imaging studies so we can assess that, again, with either a CT scan or renal ultrasound or x-rays. And then lab tests, we're going to want to, of course, do a urinalysis so we can assess crystal formation, infection, and then if there's any hematuria. Once that has been completed, our treatment is going to be for stones that are asymptomatic or causing mild symptoms. We just want to use conservative treatments. And medical management would be thiazide, diuretics, or allopurinol, which is, we think of that gout medication, can be used for calcium stones or uric acid stones. Stone removal, that would be anything that's like larger than like 5 millimeters, or stones that might be causing severe symptoms, or lithotripsy. So which would need to be stones. The doctor would go in and they would break up those stones, which would be that lithotripsy. So the goals of treatment would be acute pain management, promote passage of stones, which we would want to make sure they're drinking plenty of water, and then also having them strain when they go to the bathroom so that we can assess if they've passed. Promote passage of stone, reduce the size of stone already formed with that lithotripsy, and then prevent a new stone formation. So it is important to consider foundational knowledge about the kidneys, how the kidneys are shaped, and their external structure. So kidneys are bean-shaped organs, and they're located on either side of the spine, just below the rib cages, and they're two, and they do look like they're little kidney beans. They are situated in the retroperitoneal space. They have an external structure, and the outer layer of the kidney is called the renal cortex. The renal cortex extends into the medulla and forming renal columns, which is the innermost part of the kidney is the renal pelvis. A functional kidney, or a functional unit of the kidney, is the nephron, and each kidney contains approximately 1 million nephrons, which are responsible for filtration and processing of blood. Renal artery and veins. The renal artery branches into smaller arteries, within the kidney, eventually leading to a network of capillaries in the glomus. And then there's the renal pelvis and ureter. Urine produced by the nephrons drains into the renal pelvis, which is more of kind of like a funnel-shaped structure, like in the center of the kidney. And then from there, the renal pelvis, the urine travels through the ureter to the urinary bladder. So each kidney has a ureter, which is more of like a tube-like structure that connects the kidney to the bladder. So it's just important to kind of have a little bit of foundation knowledge on that, so that way we understand like how polynephritis happens, especially from like simple, uncomplicated UTI or like cystitis, because the infection travels up the ureter, which is that tube-like structure that connects to the kidney to the bladder. So ureters transport urine from the kidneys to the bladder for storage. The bladder stores urine until it's ready to be excreted from the body, and then the urine exits the bladder through the urethra during the process of urination. So the renal capsule is surrounded by a really tough fibrous layer called the renal capsule, which helps protect and maintain the shape of the kidney. And then it's surrounded, peritoneal fat is actually kind of encapsulates around the kidney, that provides cushioning and protection, so that way your kidneys try not to get harmed in your body and just, being out and about. Renal sinus is a space within the kidney that contains blood vessels, nerves, and then the renal pelvis. Erythropoietin and angiotensin converting enzyme. So erythropoietin is primarily obtained from the kidney. It is a glycoprotein hormone that plays a crucial role in the regulation of red blood cell production. So we know that as erythropoiesis, and then the RAS, we know it as, but it's the angiotensin converting enzymes, or the RAS symptom. It plays a crucial role in the renin-angiotensin-aldosterone system, and it's a hormonal system that regulates blood pressure, fluids, and electrolyte balances in the body, and it's made by the lung to activate angiotensin 1 in the kidneys that's primarily in the proximal tubules. So filtration. So kidneys filtration, they filtrate. They filtrate blood. Pressure is most important for the process of filtration. Reabsorption, back movement of content from the glucometer, filtration into the blood, and then excretion. This is elimination from the body, and then secretion and movement of contents from the blood to move into the nephron. So what is a healthy versus unhealthy kidney? So healthy kidneys are going to be able to function in a healthy way. They're going to be able to rid our bodies of sodium in water. They're going to rid our body of waste, and they are going to have a hormone production. Unhealthy kidneys are going to have a lot of issues. We're going to see that with fluid overload. It's going to be elevated waste, so we're going to have an elevation in urea content, creatinine, potassium, so we're going to have some hyperkalemia. We might have some changes in hormone levels that might control blood pressure, red blood cell production, and maybe some uptake of calcium. So kidneys play a huge role in hormone production, and it's typically through synthesis and activation of certain hormones that involve regulation of blood pressure and the red blood cell formation and calcium metabolism. So renin is an enzyme produced and released by specialized cells called juxtaglomerular cells in the kidneys. It also, renin plays a role in the renin-angiotensin-aldosterone system, which regulates blood pressure and fluid balance. And it acts on angiotensin, converting it into angiotensin 1, which is further converted into angiotensin 2 by angiotensin converting enzyme ACE. And then erythropoietin is the hormone we know produced by interstitial fibroblasts in the kidneys that's regulating the production of red blood cells in the bone marrow, helping to maintain adequate oxygen carrying capacity in the blood. So it's helping produce the production of red blood cells in the bone marrow, so that way it can help maintain adequate oxygen carrying capacity in the blood. And then citracal, active vitamin D. The kidneys are involved in the activation of vitamin D. This is produced in the skin or obtained from dietary sources. And that calcitrol, it plays a crucial role in calcium and phosphate metabolization, promoting their absorption in the intestines. Prostaglandins, kidneys produce prostaglandins, which are lipid compounds, and they also play a role in the inflammation response and may influence blood pressure. BNP, the natriuretic peptides, the heart produces these, and the kidneys produce brain natriuretic peptides, and these actually act to increase sodium excretion in the urine, which is going to lead to diaphoresis and contributing to regulation of blood pressure. So you can kind of see how the heart and the renal system really play with each other, because your kidneys can be damaged if your heart has issues, such as we're talking about the blood pressure. This is regulation of the blood pressure. There's something wrong with the kidneys, then we can't have proper blood flow to the heart. So a lot of times people that have heart issues have kidney problems, and vice versa. So there's 3 different types of acute renal failure. Of kidney failure, I'm sorry. We have acute renal failure, we have chronic renal failure, and we have end-stage renal disease. So acute renal failure is a sudden loss of kidney function caused by an illness, injury, toxin that stresses the kidneys out. In acute renal failure, kidney function may recover. So this might be reversible, and it is important that we get that reversed as quickly as possible, so that way we do have the time to be able to reverse that. If acute renal failure does not get reversed, or if it is goes far too long undiagnosed, it can turn into chronic kidney disease, and this is not reversible. This is a long, slow process where the kidneys lose their ability to function, and it occurs in various stages. The very last stage being end-stage renal disease, which the kidneys completely shut down and are irreversible. This is where your patients would need to have starting to get into dialysis, some part in between chronic kidney disease and end-stage renal disease. Acute renal failure, we'll talk a little bit more about. It's a sudden loss of renal function, so that can happen really rapidly. Sometimes it can happen over a few hours, days, or weeks. Critical ill patients are at the highest risk for this. This can happen from major surgery, maybe trauma, nephrotoxic medications, and I think of always like vancomycin as a vancomycin medication, so that's why we always want to watch out for that. Acute renal failure with that. Elderly, the inability to eliminate excess sodium or fluids and waste materials from the blood. In acute renal failure has fluid overload. It can cause potassium hyperkalemia, increases waste in the body, and usually is reversible. There's a couple different stages of acute renal failure. The onset is about 1 to 3 days with increased BUN and creatinine, but they normally are oligarchic, which means that they're not producing very much urine very much, and that may last up to 14 days. Sorry, I just lost my train of my thing. Sorry, I just lost my, just came off the thing. Okay, so oligarchic, so they're not producing very much urine. It's typically less than 400 mLs a day, so it's not very much at all. And then that stage could last up to like 14 days. Then they're going to get into the diuretic stage, where now they're going to produce like a ton. They're going to start producing lots, like way too much. They could produce up to 4,000 mLs a day, but no waste products. May see improvement at the end of this stage, but this is also where electrolyte imbalances could happen because of the flushing of the urine so much. And then recovery, kidney function returns to normal or may remain insignificant and become chronic. So it just depends on the stage that they're at and how we can get their kidneys back. So the lab definitions, obviously polyuria, that's a lot of urine. Oliguria is not very much urine, and then anuria is no urine, and a decrease in creatinine clearance in more than 50%, and an increase in baseline of creatinine. So if they have an increase of creatinine, that's where we're gonna end up seeing the issues with that. Pre-renal is the most common cause of acute renal failure. If it's not treated, though, it can lead to intrinsic or intrarenal failure. The damage occurs before the kidneys because it's pre, and it's typically due to reduced blood flow as a result of the signs and symptoms. So pathology of pre-renal failure, we said that's before the kidneys. There's less blood flow. It's a result of a decrease of GFR, and with a decrease of GFR, there's decreased renal blood flow. And it's typically one of the first pathophysiological responses to a decreased GFR is the activation of the renin angiotensin aldosterone system. So remember, GFR, the lower the GFR, the worsening of the kidney disease too. The renin angiotensin aldosterone system is activated in response to decrease the GFR to help maintain blood pressure, perfusion of vital organs, and fluid and electrolyte balance in the body. The activation of the RAS is a mechanism that occurs in response to reduced renal blood flow or low GFR. So some symptoms of acute renal failure could be decreased urine output, fluid retention that might be seen in like bilateral lower legs, like peripheral edema, might have some drowsiness, some fatigue, some confusion, in severe cases, maybe seizures, chest pain maybe, headache, lethargy, and nausea. More in that oligarchic phase where they're really producing a lot of urine. It's going to be less than like 400 mLs a day. They might be having more of an increased BUN, creatinine, might be having more heart failure or maybe some pulmonary edema. They also might be having some hypertension, some disorientation, vomiting. During that diuretic phase where they're producing a lot of urine and more of like 4,000 mLs per day. Remember we talked about how they're probably going to be having some electrolyte imbalances, such as flushing of the urine so much. So you're going to see a lot of low electrolytes, such as hypokalemia, hyponatremia. We're going to see some tachycardia because our body is trying to compensate now. They are going to have improved level of consciousness, but that's just due to the loss of nitrogenous waste. So the level of consciousness and alertness is improving due to the urine being flushed of the toxins. So the types of we have an intrarenal, and that's due to the processes that directly damage the kidneys. So that could be glomerulonephritis, some rhabdomyolysis or tumoritis syndrome. That could also be a type, the intrarenal, which is like into the kidney. That could be from contrast dye from like a procedure. So if somebody was getting like an MRI with contrast dye and they were at risk for kidney issues, that would be something that you would probably want to opt for, maybe like an ultrasound instead, or maybe without dye procedure due to the risks associated with intrarenal acute renal failure. So with intrarenal, remember that one of the functions of the tubules is reabsorption of sodium and water. So if the injury is within the kidney itself, it will cause that area to lose its function. So it's not going to be able to do that, to have that reabsorption of sodium and water. So some examples of renal diseases, like we talked about, is that we can have the most common cause of intrarenal disease is tubular related, and that is 85% the most common, and that causes ischemia and toxins and acute tubular necrosis. So that is the most common type, tubular intrarenal disease, 85%, most common. And then postrenal is that obstruction, and that's caused by disease states located downstream of the kidney, and most often occurs as a consequence of urinary obstruction. So this is what causes that benign prostatic hyperplasia, kidney stones, obstructed urinary catheter, bladder stones, maybe some cancer of the bladder, ureters, or prostate. So diagnosis of acute renal failure would be signs and symptoms that might prompt further evaluation. So that would be the urine output amount within a 24-hour period of time, analysis of a urinalysis, blood tests such as BUN and creatinine, which would typically be shown as high, imaging tests such as kidney ultrasound and or CT scan, and possibly a kidney biopsy. So what is the treatment for acute kidney failure? Well, immediate treatment of pulmonary edema and hyperkalemia, because that might be issues that might be happening. We want to remember that this is most likely reversible. If we need to do dialysis, like to control the hyperkalemia or pulmonary edema, that might be indicated. Metabolic acidosis or uremic symptoms. And then usually during this time, we educate the patient to follow a strict diet, restricting them of sodium, and then possibly a fluid restriction, and potassium. Water and potassium intake is normally restricted, but and then just typical adequate protein. And then they might need possible phosphate binders. Chronic renal failure. This involves progressive, irreversible loss of kidney function, and that's either defined as either kidney damage, that might be pathological abnormalities, or a GFR that's less than 60 for 3 months or longer. So we already talked about the stages of kidney failure, 1 through 4, basically. Sometimes it can be 1 through 5. 5 is typically less than 15% GFR, and that's when you really have that's very bad. And then causes of chronic kidney disease. Chronic kidney disease is glomerulonephritis, which is the most common cause. Diabetes, hypertension are typically seen as the most leading causes, as well as tuberous interstitial nephritis. But glomerulonephritis is typically the most common, as well as diabetes for chronic kidney disease. And then these stages, again, which would be stage 1 through 4. 5 would be like less than 15% GFR. So basically the symptoms are just about the same as acute renal disease, except they're going to have poor skin turgor. So that means that their skin is going to tent. They're going to have confusion. They're going to have a salt overload. They're going to have accumulation of potassium, muscle weakness, fluid overload, and probably showing some signs and symptoms of metabolic acidosis. So maybe some proteinuria, and then their urine is probably going to show red blood cells, white blood cells, and some casts. And we talked about earlier about how cardiovascular system can affect the kidneys, and so there can actually be some symptoms of cardiovascular in a patient with chronic kidney failure, such as hypertension. They might have some arrhythmias, especially from that hyperkalemia, pericardial infusion, and heart failure, and then peripheral edema. They also might have some neurological symptoms, such as neuropathy, motor and nerve dysfunction, maybe some muscle cramping, and that's probably due to the electrolytes and the potassium, and then obviously the sodium too. Shortened memory span, drowsiness, and maybe some confusion. Might also have some GI symptoms. You could get pancreatitis, ulcers, or stomatitis. Uremic factor, which is a urine-like odor on the breath of people with uremia. So the odor could occur from the smell of ammonia, which is created in the saliva as a breakdown of product of urea. So uremia, their breath could smell. They also might have some vomiting or some constipation. Could have some respiratory issues, some pulmonary edema, pleural fiction rub and effusion, or Kussmaul's respirations from like an acidosis. Endocrine wise, they could have some amenorrhea, which is that lack of menstrual period in women. In males, they might have some impotence. They might have some stunted growth in children, and then maybe some thyroid or parathyroid issues or impaired glucose levels. Hematology symptom wise, they could have anemia. They could have some blood loss from maybe like a GI bleed or dialysis. So that's also something definitely important to know. And then skeletal system, we talked about muscle and bone pain, bone mineralization due to the issues with the electrolytes, demineralizing the bones, which can lead to pathological fractures, especially if they are elderly. That's putting them more at a higher risk of fractures. And also can cause some vessel calcifications in the heart, joint, eyes, and the brain. And then skin, they can have purpura, pruritus, which is that itchies, uremic frost, thin brittle nails, dry brittle hair, alopecia, that loss of hair, and then on yellow bronze skin with like a pale color. And then they also typically present with metabolic acidosis with chronic renal failure. And this is, it is not due to overproduction of acids, but it's rather a reduction in renal mass decreased that limits amount of HCO3 that can be generated. So what is the labs that we would normally do for distinguishing and diagnosing chronic renal failure? It would be a BUN. That's an indicator of a GFR that is affected by the breakdown of protein. So the normal GFR is 10 to 20. And so the way that I remember a normal GFR is I think of like a hamburger bun, like a BUN bun. I think of hamburger bun and I think about a good hamburger typically costs about $10 to $20 if you're in a restaurant. So I think about if you want a really good hamburger that's like mwah, like so good, it's going to be about $10 to $20. Okay, and so that's how I remember what we want to have as at that. When it reaches 70, that's when we have issues with dialysis. But a BUN, a good BUN number is about 10 to 20. Don't get that confused with GFR, but a BUN is a normal one is 10 to 20. Serum creatinine is the waste product of skeletal muscle breakdown. And it's a better indicator of kidney function, and that normal is 0.5 to 1.5. So anything over 1.5 is high for creatinine. So creatinine, if it gets too high, that is when those waste products are not going to be able to be excreted as well. Creatinine clearance is best determinant of kidney function, and it must be a 12 to 24 hour urine collection. So if we're wanting our patients to do like a creatinine clearance, they would pick up like a liter or two at the lab, and they would take those home and they would collect that urine for 12 to 24 hours and then return that back there and have that tested. Continuing on with labs, potassium. So kidneys excrete the potassium. So the normal potassium is 3.5 to 5.5. So anything higher or lower would be considered off. Potassium maintains muscle contraction, is essential for cardiac function. Both high and low values can cause problems with cardiac rhythm. And then hyperkalemia, which is high calcium or high potassium hyperkalemia, is treated with IV glucose and sodium bicarb to push potassium back into the cells. So We treat hyperkalemia with IV glucose and sodium bicarb to push potassium back into the cells. Calcium, we want to check their calcium level. So with decreased kidney, the enzyme for utilization of vitamin D is actually absent. So calcium absorption depends on vitamin D. So that's why when people are typically taking supplements with calcium, we normally want to also encourage them to take vitamin D as well. Body moves calcium out of the bone to compensate with that. So calcium comes with phosphate bound to it. So a normal calcium level is about 4.5 to 5.5. And if it's lower than 4.5, that would be hypocalcemia, and anything higher than 5.5 would be hypercalcemia. And we want to make sure that they are avoiding antacids and magnesiums during this time. So some management of chronic renal failure would be treat comorbidity conditions, because if the heart and other things are affected at this time, it's going to only further progress the chronic kidney failure. We want to make sure that we are maintaining IV glucose and insulin. If we have higher levels of potassium, hyperkalemia, we want to maintain that with IV glucose and insulin, sodium bicarb, calcium, vitamin D, phosphate binders. In general, they might need some iron supplements, and then we want to encourage them to have a low protein diet. And then if all else fails, at the end stages, they might need some dialysis. Is based more on the patient's symptoms than like the GFR. But that is also very important that they start that too, if that's what they're wanting to do. And I think that about wraps it up.